Welcome back, fellow mitochondriacs, for another episode of Cancer as a Mitochondrial Metabolic Disease. We are back today to talk more about a key enzyme called PFKFB. And in the last video, we were able to cover kind of like what it is, what its role is, how it the glycolysis state or the Warburg effect for cancer. I think this is probably one of the better graphics here, looking at how PFK 3 and 4 will, as this paper was titled, it will fine tune the glycolysis for cancer. And if the cancer cell needs a very specific amount of energy for growth and metabolism, then it will turn up the PFK enzyme. And if it needs more substrates, or if it needs more help from an antioxidant perspective and maintaining redox homeostasis, it will shunt the glucose to or through the PPP, or the pentose phosphate pathway. So this is a very interesting kind of like, it's not really a main part of glycolysis classically, it's not like one of the main enzymes, but it's an enzyme that's kind of off to the side that it detects the state of the cell to know where the glucose that is being massively uptaked into these cancer cells to control or to lead to uncontrolled growth and survival. It helps kind of fine tune that process. And we've seen it in other models, like in this glioblastoma model, having effects on the cell cycle, on the making of new blood vessels, on DNA repair, etc. And we also saw that it was under the control of multiple signaling cascades, including the ER-PR positive found in breast cancers, EGFR, and likely HER2, as we saw in one of the papers for HER2 positive breast cancers, inflammatory cytokines, stress signals, hypoxia or pseudohypoxia, even increases in glucose and insulin can also upregulate this, which kind of shows the landscape of why this is upregulated and how, and if we're going to have a chance against trying to downregulate this or to shut this process off, it gives us some potential targets. Now, what we were not able to do is actually get into the inhibitors of PFKFB in the prior video. So I'm going to start with this paper here. It was published in June of 2022, and it's titled Treatment Against Glucose-Dependent Cancers Through Metabolic PFKFB3 Targeting of Glycolytic Flux. And it says here, a critical step in glycolysis is controlled by the enzyme 6-phosphofructose-2 kinase, fructose 2,6-biphosphatase 3, PFKFB3, which is why we call it that, because it's a mouthful, which converts fructose 6-phosphate, F6P, to fructose 2,6-biphosphate. Fructose 2,6-biphosphate allosterically activates the rate-limiting enzyme glycolysis catalyzed by PFK1. Remember, we have PFK1, which is a main rate-limiting enzyme within the glycolysis program, or within the glycolysis system, which is feed forwarding the Warburg effect in these cancer cells. And this fructose 2,6-biphosphate here is activating PFK to allow that glucose to be further metabolized down to pyruvate and lactate subsequently. And so what we're effectively trying to do is trying to take this enzyme here that converts this 2,6-BP and shut it down so it can't activate PFK. It's kind of a roundabout way of trying to shut down glycolysis. We've already talked about things that can inhibit PFK directly. Now we're talking about kind of an indirect way of blocking it. FB3 is often overexpressed in many human cancers, including pancreatic cancer, colon, prostate, and breast cancer. Hence, PFKFB has gained interest as a compelling therapeutic target. While much remains to be learned, PFK3FB continues to hold great promise as an important therapeutic target, either as a single agent or combination with current interventions for breast and other cancers. And so one of the reasons I pulled this particular paper is because it had this table. And this table gives us at least some of the landscape of possible, and I do say possible for a very distinct reason, PFKFB3 inhibitors. And probably one of the more classically well-known inhibitors is 3PO. And then we'll talk about PFKF15 and PFK158. We're not going to really talk about much of the other ones. So the next paper was way back in January of 2008, and it was titled Small Molecule Inhibition of 6-phosphofructo 2 kinase activity suppresses glycolytic flux and tumor growth. So this is not like a new discovery. They've known about this for nearly 20 years, but this is an important target and have been developing small molecule inhibitors. And as we'll see, there's also natural inhibitors as well that have an effect here. But despite how kind of bullish this 2022 paper says, this, you know, holds great promise as an important therapeutic target, still it's not in production or in any standard of care at this point. So a lot of times these things get unfortunately developed, seen as a good target, and then it doesn't move forward in the clinical evaluation process and gets shelved and forgotten about, and then probably off patent, and then they won't take it forward. So anyway, 3PO, PFK, and PFK158 are when we talk about. And so in this paper, it says, we report herein the computational identification of a small molecule inhibitor of PFKFB3, and it says 3PO. It's a very long word, and it's not really that important for us. So 3PO, which suppresses glycolytic flux and is cytostatic to neoplastic cells. 3PO inhibits recombinant PFKFB3 activity, suppresses glucose uptake, and decreases the intracellular concentration of 2,6-biphosphonate, lactate, ATP, NAD, and NADH. 3PO markedly attenuated the proliferation of several malignant hematopoietic and adenocarcinoma cell lines with a 50% concentration needed at 1.4 to 24 micromoles per liter, and is selectively cytostatic to RAS-transformed human bronchial epithelial cells relative to normal human bronchial epithelial cells. So it sounds like it's pretty promising. It's lowering all the right things you would see. And that's what's a little bit confusing about this paper, because it actually does lower the amount of fructose 2,6-biphosphate, as well as lactate, ATP, NAD, NADH, etc. And so just looking at some of these graphics that were part of the paper, we see here that the tumor mass, when given 3PO, is much lower at day 14 than if you were not giving anything to just allow this is a lung cancer model, to grow, right? We're seeing about a more than threefold decrease at 14 days with this 3PO by itself. Then they looked at another model. I want to say this is a skin cancer model. I'm not sure. MDA. I think it's actually a breast cancer model. I've seen that MDA MB231 several times. I think it's a breast cancer model, and we see it's even more exaggerated. You know, we see about a 4-fold decrease at 14 days of slowed down growth. We see it effectively stop growth. I mean, you see it about 150, milligrams at day 0, and we see it slightly lower. So it's effectively shutting down the Warburg effect and shutting down growth. Whereas if you didn't give it, it would just continuously kind of exponentially grow. And then the same for this HL60. I have to look into the literature to see what HL60 is, but it's another tumor type. And we see here that it effectively shuts down growth also. And in this case, at the end of 14 days, it was about 400 here, and it was about 1,500 for the placebo model or whatnot, or the sham drug. And so we're talking about a more than threefold decrease in growth potential in that model as well. So the bottom line is this 3PO seems like it could be pretty cool, and it could actually help us quite a bit in our endeavors. Let's go further. So this paper is the reason why when we actually get down to the PFKFB inhibitors, I have a question mark here, because according to this study, where the heck was it? According to this study, there was less fructose 2,6-biphosphate available, suggesting that this enzyme activity was suppressed. This PFKFB3 was suppressed. However, a later study, about 12 years later, this paper was published in September of 2020, saying small molecule 3P inhibits glycolysis, but does not bind to basically PFKFB3. And it says here, however, 3PO did not bind to PFKFB3, even at 750 micromoles, which is much lower than the concentrations they were talking about in that last paper, in contrast to 3 micromoles of AZ67, another like possible runner for an inhibitor for this particular enzyme, which is a potent and specific PFKFB3 inhibitor. Instead, 3PO accumulated lactate inside the cells, leading to a decrease in intracellular pH and inhibition of enzymatic reactions of the glycolytic pathway. And I'm actually blanking if we actually had talked about, I actually think it was maybe aspirin that somehow acidified the intracellular environment, which led to glycolysis shutting down. And then that was at least one of the mechanisms at a higher dose of how it worked. Whereas in this case, 3PO, they believe that it may be also inhibiting a lactic acid channel. So that way the lactic acid that's actually made by glycolysis will build up inside the cell, not get outside the cell to make the tumor microenvironment shield system. And then the change in pH, which is very sensitive to cancer cells, but also all enzymes are very sensitive to pH. That decreasing pH by increasing lactate within the cancer cells is actually what led to their demise. So my point by all of this is that sometimes in science, we think we know, things like in this particular paper in 2008, and it still may be true because, there were very specific kind of evidences that it does maybe inhibit PFKFB3. No matter what, it does shut down glycolysis, and it does lead to cancer cell death, but maybe through a different mechanism. So therefore, it may not be a PFK3 inhibitor. In the discussion of that paper, it says that indeed, using seahorse technology, we could demonstrate that 3PO inhibits glycolysis in a concentration-dependent manner, resulting in an up to a 50% reduction in glycolysis. Importantly, 3PO does not inhibit the enzymatic activity of other enzymes involved in the glycolytic pathway, such as hexokinase, glucose-6-phosphate dehydrogenase, transskeletalase, glyceraldehyde 3-phosphate dehydrogenase, pyruvate kinase, lactate dehydrogenase. The question remains in the mechanism responsible for the inhibition of glycolysis by 3PO. The present study shows that the inhibitory effect of 3PO on glycolysis relies on the ability of this compound to cause an imbalance in pH inside the cancer cells by accumulating lactic acid inside the cell. It is known that some glycolytic enzymes, including lactate dehydrogenase, phosphofructokinase 1, are very pH sensitive. A change of less than 1 unit of pH, even a few tenths of a unit, may reduce the activity of PFK by more than 10-fold. So, we wanted, in the PFK video, let's see here, where was it? In the PFK video, I thought I had it up here. I may have taken it off because I found that it didn't do that. But we wanted a PFK inhibitor, and I think that there was some paper that suggested that maybe 3PO did it, and then it said no, actually the real mechanism was through PFKFB, which got me down that rabbit hole. And then now we're seeing that the mechanism may actually be an inhibition of PFK, but not in a direct binding, but by changing the intracellular pH, and by some of these enzymes are extremely pH sensitive, it actually shuts it down kind of by a roundabout manner. It still didn't really answer the question, to my liking at least, how it does it, but I would guess that it's probably blocking a lactate channel, because lactate should go outside the cell through these MCT transporters. I don't know if it's in one of these. See, lactate is shown here, but it doesn't show it leaving the cell. What should happen is there's these lactate transporters, and that lactate transporter should allow lactate to leave and set up the tumor microenvironment. And my guess is the only explanation really, because if you've not inhibited lactate dehydrogenase and it's actually allowing pyruvate to get through to lactate, then it's got to go somewhere. And I'm guessing that it must be blocking the channel, but that may come in future papers or endeavors. So moving on from PF3PO, the next compound that I want to talk about is PFK15. And this paper was published a year later in March of 2021. Inhibition of glycolytic activator PFKFB3 suppresses tumor growth and induces tumor vessel normalization in hepatocellular carcinoma. And it says basically here that glycolysis emerges as a new therapeutic target for malignancies. New. Not remembering that Otto Warburg talked about this 100 plus years ago, and Dr. Siegfried's been talking about it for more than 20 years. But it's a new, apparently, therapeutic strategy to target malignancies. The inhibition of glycolytic activator PFKFB3 repairs tumor endothelial cell function and normalizing the tumor microenvironment. We aimed to investigate the significance of PFKFB in these hepatocellular carcinoma or liver cancer cells, and the effect of the PFKFB3 inhibitor PFK15 in hepatocellular carcinoma tumor cells and endothelial cells. Double immunofluorescence staining of PFKFB3 and CD31 in hepatocellular carcinoma tissue revealed that high PFKFB3 expression in both tumor cells and tumor endothelial cells was significantly correlated with poor prognosis, which makes total sense, because if you got a bunch of PFK around, that means either growth signals are upregulating it, or it's allowing the Warburg effect to propagate and actually get worse. And we also know that from prior videos that PFKFB3 is responsible for, at least partially responsible for, the activation of new blood vessels for tumors. So therefore, if you inhibit it or have it out of control expression of it, it would lead to a poor prognosis. That makes a lot of sense. Multivariate analysis identified that PFKFB3 expression is an independent prognostic factor. PFK15 suppressed proliferation of HCC or hepatocellular carcinoma cell line with tumor endothelial cells. PFK3 suppressed tumor growth and induced apoptosis. Moreover, PFK15 treatment-induced tumor vessel normalization, decreasing vessel diameter with pericyte attachment and improving vessel perfusion. High PFKFB3 expression in both tumor cells and tumor endothelial cells was identified as a novel prognostic marker in hepatocellular carcinoma. My guess is it's probably all cancers, given its central role in glycolysis and the fact that the Warburg effect and substrate level phosphorylation, the enhanced glucose uptake and utilization by cancer cells, is a hallmark of cancer. Therefore, it's likely in all cancer cells. This group was studying liver cancer. Targeting PFKFB3 via PFK15 may be a promising strategy for suppressing tumor growth and inducing tumor blood vessel normalization. Pretty cool. So we have abnormal tumor cells. We see that when we block PFKFB3, it actually starts to normalize those tumor cells. And then, of course, looking at glycolysis and how it actually works, it's feed forwarding glycolysis, right? Because it activates PFK. And when we block it, it shuts that process down to some degree, and it leads to lower amounts of metastases, lower amounts of growth, just an overall better prognosis compared to the unrestrained amount of PFKFB3 and glycolytic activation that's happening within the normal, in this case, hepatocellular carcinoma or liver cancer. Moving forward, combination of 3PO analog PFK3, PFK115, SI-PFKL efficiently suppresses the migration, colony formation ability, and PFK activity of triple-negative breast cancers by reducing glycolysis. Among the subtypes of breast cancer, triple-negative breast cancer, TNBC, has been shown or has been associated with the worst prognosis. Recently, for many solid tumors, including breast cancer, metabolic reprogramming has appeared as a cancer cell hallmark, and the elevated glycolytic pathway has been linked to the aggressive phenotype. As fructose 2,6-biphosphate has been associated with increased PFK1 activity, the effect of PFKFB inhibition by PFK15 was investigated on two major isoforms of phosphorus in breast cancer. That is phosphorus platelet type and phosphorus liver type, relevant to breast cancer. For PFKL inhibition, the siRNA approach was used. PFKFB expression was significantly correlated with inferior overall survival in breast cancer patients, including triple-negative breast cancer. So it's basically all breast cancer. It's just including triple-negative, which is one of the more difficult ones for conventional medicine to treat. PFK15 treatment of triple-negative breast cancer cells, MD-MB231. So that was definitely a breast cancer model back in that other paper. MD-MB468 resulted in decreased PFKP expression, therefore leading to reduced colony formation ability, migration rate, and extracellular lactate levels. However, to our surprise, PFK15 treatment in both triple-negative breast cancer cells also resulted in elevated PFKL levels. Our results demonstrate that the combination inhibitory of PFK15 and SI-PFKL was more effective in triple-negative breast cancer cells, as it led to an increase in colony formation ability, migration, extracellular lactate levels, and PFK1 activity when compared to individual treatments. So this is a key point, and I'm trying to think the best. So let's look at this. So what they're saying here is that, let's see here, just I want to quickly clarify make sure I'm on the right track here. So we've talked about this when we were talking about the PFK enzyme, okay? PFK here, PFK1. So this is how the roundabout way of how PFK3B is upregulating PFK. Well, PFK here is not specified which isoform it is. There are, if I'm not mistaken, there were 3 isoforms. There's liver, platelet, and muscle. And in cancer, it seems like platelet type is the most dangerous, followed by liver and then muscle. And what they did was they used PFK15 to basically block this PFKFB enzyme, which lowered the amount of fructose 6-biphosphate, which ultimately downregulated and I believe lowered the expression of PFK platelet type. But as a fallback mechanism, the cancer upregulated the other isoform of PFK, PFKL. And so what they did was they saw that even though they gave PFK15, the inhibitor of this enzyme, and it had an effect, the kind of salvage pathway was activated, and therefore PFKL was upregulated. And so they did was they used another medication. They used what the heck did they use? They used this SI-PFKL, right? They use this and they showed that in combination, it clamped down both isoenzymes or both isoforms of the enzyme, which basically shut down the Warburg effect, and it was more effective at these in this triple negative breast cancer model, as it led to decreasing colony formation ability, migration rate, extracellular lactate levels, PFK1 activity when compared to individual treatments. So if they gave one, the other one would upregulate. If they gave one, the other would upregulate. If they gave both, that was enough to have a better effect, or more, maybe a more sustained effect was a better way to say it. Moving on. So there's another PFKFB3 inhibitor, and that was called PFK158. And so this paper was published in January of 2019, therapeutic targeting of PFKFB3 with a novel glycolytic inhibitor. PFK158 promotes lipophagy and chemosensitivity in GYN cancers. And it says here that metabolic alterations are increasingly recognized as important novel anti-cancer targets. Among several regulators of metabolic alterations, fructose 2,6-biphosphate as a critical glycolytic regulator, inhibition of the active form of PFKFB3 using a novel inhibitor, PFK158, resulted in reduced glucose uptake, ATP production, lactate release as an induction of apoptosis in GYN cancer cells. It says later that finally, in a highly metastatic PTX, paclitaxel resistant in vivo ovarian mouse model, a combination of PFK158 with CBP, carboplatin, significantly reduced tumor weight and ascites, which is like buildup of fluid around the organs and the peritoneum, and reduced LDs, lipid droplets, sorry, they're using acronyms that I didn't read yet. Reduced LDs in tumor tissue as seen by immunofluorescence and transmission electron microscope compared to the untreated mice. Since the majority of cancer patients will eventually recur and develop chemoresistance, have someone say that in the conventional literature often. Since the majority of cancer patients will eventually recur and develop chemoresistance, our results suggest that PFK158 in combination with standard chemotherapy may have a direct clinical role in the treatment of recurrent cancer. I guess that's one way to do it. You know, the other way would be to actually treat cancer as a metabolic disease, which you're doing with PFK158, but then relying back on the standard of care. I think that the combination of metabolic inhibitors, which have no or little effect on our normal cells, is going to be a better strategy than looking for old strategies after you've uncovered sensitivities to those strategies. But that's just my one person's opinion. I'm going to take a break here for a second because we have some more to cover here in this video. But I don't have a lot of extra time, believe it or not. I do have enough time to research this, thank God, and present these live streams now, which helps me a lot because it doesn't require me to do any editing. Now, it doesn't give me as much of a beautiful finished product, I guess you'd call it, and it definitely has, I would say, hurt the channel probably to some degree by not having published videos. But I'm going to start doing at least some published videos, and I have my family coming in next week, and so I really don't want to do live streams and be here. We're going to go to the beach and we're going to have fun down here in Florida. And so my point by saying that is I've actually produced a video, first video I've produced in a while. As a matter of fact, I have to look back to see how long it's been. It's been probably at least 3 or 4 months, if not longer, since I've actually produced a video since not doing these live streams. And I love the live streams. I think there's a simplicity to it because I don't have to edit things. And there's a nice camaraderie to it because I have nice folks in the chat who are, liking and commenting and so on and so forth. So therefore I do enjoy it, and I'm going to continue to do it. because it's not like my time has magically came back, and I don't have time to spend 10 hours editing videos in addition to shooting them. But that being said, because of next week, I'm not going to be doing any live streams. So I did produce a video for next week, and it is on a topic that I think is going to excite a lot of you, and that is going to be ivermectin. And what I realized after I got through the first video, which is going to be nearly 30 minutes long, a produced video, I'm going to have about 3 of them because I have so much information that I was able to pull from the medical literature about ivermectin and its potential help for cancer. Now, it has effects that are peri, I guess you'd say, to PFKFB3. I didn't see there was any effects on PFKFB3, but there's a whole host of effects on glycolysis as a whole, as well as glutamine inhibition. And we're going to basically hammer that. I'm going to drop that video on Monday. So I just want to give you the heads up that there will be no live stream Monday, but there will be a video produced that will be uploaded, and it will be the first of probably 3 videos on ivermectin. So moving back to PFKFB3. All right, the next paper was published in February of 2021, also talking about PFK158 again. And it says inhibition of PFKFB3 induces cell death and synergistically enhances chemosensitivity in endometrial cancer. So the last paper was talking about PFK3 in GYN cancers, but then it specifically talked about a case of paclitaxel resistant ovarian cancer and how PFK158 had a synergistic role with carboplatin, a standard of care medication. And so what this paper is kind of showing us is that because cancer, when treated as a metabolic disease and utilizing one of the major hallmarks of cancer, which is that cancer is utilizing glucose on the order of 10 to 30x more. Warburg effect, substrate level phosphorylation, enhanced glutaminolysis. Of course, PFK158 has an effect on ovarian cancer. And of course, PFK158 is going to have an effect on several other cancers, including endometrial cancer. I think we've done ourselves a big disservice by making cancer more complicated than it needs to be. And I get the reason for it. Maybe if we had no idea about Otto Warburg, if we had no idea about Thomas Seyfried, if we had no idea about Thomas Durage and his whole, entourage up at Boston College and other wonderful researchers who are bringing this information to us. I mean, none of these papers are from Seyfried. So these are all from other groups around the world. And I thank them for their contribution. But if it's not clear at this point of the series, is that all cancer relies on this. So therefore, it's not going to be surprising that it's going to have an effect on these hepatocellular carcinoma liver cancer cells, or these ovarian cancer models, or this breast cancer model that's triple negative, or this uterine cancer model, right? Endometrial cancer. It's not going to be surprising that it's going to be a pan effect across pretty much all cancers, because it is a hallmark, and that's what's going to be the case. But we're going to see it. We're going to see it used in very specific cancer models, and it's going to give us the illusion that it's only going to be effective for endometrial cancer or ovarian cancer or whatnot, right? But we have to kind of zoom out for a second and say, okay, this is affecting a major pathway of cancer survival as a whole. So therefore, it's likely going to be able to be extrapolated into other models. But we're using the literature that we have. So it says here that the advancement or recurrent endometrial cancer, EC, has a poor prognosis because of chemo resistance. PFKFB3, a glycolytic enzyme, is overexpressed in a variety of human cancers and plays important roles in promoting tumor growth. Here, we showed that the high expression of PFKFB3 in endometrial cancer cell lines associated with chemo resistance. So basically what they're saying is that PFK3FB upregulation is actually what leads likely to chemo resistance, at least in some way, shape, or form. Physiological inhibition of PFKFB3 with PFK158 or genetic downregulation of PFKFB3 dramatically suppressed cancer proliferation and enhanced the sensitivity of endometrial cancer cells to carboplatin and cisplatin. Moreover, PFKFB3 inhibition resulted in reduced glucose uptake, ATP production, and lactate release. Well, of course, that's what it does. That's what it does. It upregulates the Warburg effect. It upregulates PFK activity. And therefore, we're going to make ATP. We're going to make lactate. We're going to make all the things that keep these cancer cells alive, right? So if you inhibit that process, of course, you're going to see lowered amount of those things. This is a really beautiful graphic, and it's one of the reasons I wanted to pull this paper. So we see here, we have an endothelial cancer cell, and we have chemotherapy, and we have glucose, and we have activation and inactivation. So we see here that glucose is going through this glucose transporter, the GLUT transporters. It's going to get converted to glucose 6-phosphate by hexokinase, and then further converted to fructose 6-kinase. That's going to be further converted to fructose 1,6-biphosphate by fructokinase 1. And there's a bunch of other steps that's not shown here. Ultimately, you end up in pyruvate, ultimately lactate through lactate dehydrogenase and glycolysis, right? And so what we're seeing here is that PFK158 is having multiple effects on the cell. Now, we're only looking at it in the last couple of papers looking at PFKFB3 inhibition, but it looks like it's also having effects on the AKT mTOR pathway, as well as it looks like maybe DNA repair as well. So that way it has multiple effects at lowering the amount of glycolysis happening, lowering the amount of ATP, lowering the amount of lactate, to set up the tumor microenvironment, also upregulating autophagy and apoptosis within cancer cells, as well as increasing DNA damage because it's blocking some kind of DNA repair mechanism. And then chemotherapy comes in and kind of finishes the job because now there's chemosensitivity that allows it to do its job, what is maybe was doing before it was, immune or before it was resistant. So again, this is likely a model going forward, and it doesn't have to be PFK3. Insert whatever metabolic inhibitor possible. Insert mebendazole. Insert metformin. Insert atorvastatin. Insert Bumex, believe it or not, of all things. Insert EGCG. Insert berberine. Insert whatever. Right? We see this time and time and time again. Insert X metabolic inhibitor that has some effect on glycolysis, some effect on glutaminolysis, and you see all of a sudden chemotherapy, which was locked out, is now unlocked, and it does its dirty work within the cancer cells. The issue is that chemotherapy does its dirty work within normal cells too. So that's why I don't think this is a winning strategy long term. I think what we're going to see is we're going to see a combination of metabolic inhibitors that specifically look at the Achilles heels of cancer only, not normal cells. And that's going to be further mitigated by a person being on a ketogenic diet and fat adapted so that they'd have even less side effects of having glycolysis or glutaminolysis being blocked. But that is, at this point, still a bit of a pipe dream, at least within the conventional system. The next paper is talking about PFK3FB inhibition again, but in this case, we're looking at myeloma cells. So this paper was published in May of 2022, therapeutic targeting of PFKFB3 and 3 and NB4 in multiple myeloma cells under hypoxic conditions. And it says here, treatments with PFKFB3 inhibitor, PFK158, and PFKFB4 inhibitor, 5-MNFPN, were found to inhibit the growth of myeloma cells. The combined treatment of myeloma with carfilzomib and PFK158 or 5-MPN was more cytotoxic than either drug alone. And I'll be very honest with you, I'm not familiar with this, monoclonal antibody here they use for myeloma. But that being said, it makes a ton of sense that by blocking PFK3FB, you would have an enhancement upon the standard of care, just the fact of the way it works. And I think I'm pretty sure that I wanted to pull this paper in particular because, the non-solid tumors don't get a lot of love. And so therefore, anytime I can find a hemopoietic or, blood dyscrasia or whatnot, such as myeloma or leukemia, lymphoma, et cetera, if I can find papers that kind of reinforce that this is going to be effective for those type of cancers as well, I think that I always like to show it, because I think a lot of people who see the work that's put out by the literature, and also see, work done by others, and then my presentations as well. A lot of times, we're dealing with, GYN cancers or liver cancers or breast cancers or glioblastoma or, colon cancer or whatnot. And I think that a lot of people with certain specific types of cancer feel a little left out, and like they're not going to be able to be benefited by treating cancers and metabolic disease. And, the man himself, Dr. Seyfried, said that they have not tested one type of cancer that is able to have uncontrolled growth when glucose and or glutamine are blocked. So these are hallmarks of cancers because they're part of all cancer. And sometimes we get into our little prostate cancer bubble or our little lung cancer bubble or our little, whatever else kind of a cancer bubble. And we believe that we can't take part in this larger discussion about cancer as a metabolic disease relying on glucose and glutamine, as we've talked about over the past many, many months. Next paper. Let's get into some other things besides these research chemicals, the PFK15, the PFK 158, the 3POs. What about repurposed medications for this target? Well, I found a couple. This paper was published in June of 2021. Metformin prevents PFKFB3 related aerobic glycolysis from enhancing collagen synthesis and lung fibroblasts by regulating AMP kinase mTOR pathway. And it says here, however, this inhibitory role of metformin on PFKFB3 mediated aerobic glycolysis and collagen synthesis was prevented by treatments with 3-BDO and compound C, which are specific mTOR activators and AMPK inhibitors, respectively. Taken together, the findings from this study suggest that metformin may prevent PFK3FB associated aerobic glycolysis from enhancing collagen synthesis and lung fibroblasts via regulating AMPK mTOR pathway. So this is pretty exciting because it just gives us another, I guess you'd say, notch under the belt of metformin. I'll be very frank with you. I'm not a huge fan of using medications for diabetes. I'm not a huge fan of using medications like metformin for preventive medicine, just because it has inhibitory roles on mitochondrial function and makes, it shuts down cytochrome 1. But I do think that some of these medications that have been around for years and years and years, like, metformin, like mebendazole, like ivermectin, like aspirin, like statins potentially, as well as many other repurposed medications. I do think that given their long record of relative safety, I think that you could take your medication hating hat off, okay, and realizing that there's long-term damage that we do not want to incur by being on these medications for a long time. I think that you can step outside of that and be more objective and say, hey, there are some pretty key roles that these repurposed medications could play in a very limited amount of time for a very specific goal of getting this cancer to a no evidence of disease or eradication state, or at least shut down. And maybe these medications could be used in that purpose for a short period of time, knowing that maybe long-term use of these things is not ideal. But I do think that the use of metformin in particular, I'm much more bullish over today than I was 6 months ago. And I'm definitely much more bullish over it today than I was a year ago. So in papers like this and other papers that we've looked at and other videos that have got me to that point, basically it's the amount of sheer evidence of different pathways that metformin in particular can have an effect on for cancer. I think it makes me much more bullish. So what about natural things? Well, there's a couple things that I was able to find. One of which is this L-amine. And so this paper was published in January of 2024, and it's titled Targeted Metabolomics Reveal PFKFB3 is a key target for L-amine mediated inhibition of glycolysis in prostate cancer cells. It says here that in this study, we discovered that L-amine has remarkable anti-prostate cancer activity in both in vitro and in vivo settings, comparable to clinical chemotherapeutic drugs, but with fewer side effects. Using our established targeted metabolic or metabolomics approach, we demonstrated that beta-L-amine, L-amine's primary component, effectively inhibits glycolysis in prostate cancer cells by downregulating PFKFB3 expression. So again, another group of folks who are not sure if they're on board with a high-fat diet and a ketogenic diet for cancer is the prostate cancer group. No question. They have been led to believe, I believe, by other influencers and even some very confusing titles of papers that don't really pan out to be the case, that prostate cancer can use fat for fuel. And that is, as of what I've seen so far, not true. And that, being on a ketogenic diet is not going to be helpful for prostate cancer. And we're seeing over and over again evidence, breadcrumbs, that is not the case. And this is another breadcrumb where you see that when you inhibit PFKFB3, a key glycolytic regulator enzyme, that you see that prostate cancer is actually improved, both in vitro and vivo settings. So again, the story is being laid out one paper at a time. Moving on. So the next inhibitor that I wanted to talk about was berberine. And this paper was published in April of 2022, and it's titled Berberine Attenuates Cell Motility via Inhibiting Inflammatory Mediated Lysyl Hydroxylase 2 and Glycolysis. And I had to dig into this paper to find it. But it says, moreover, the gene expression of key enzymes involved in glycolysis process, including PGK1, PGAM, PFKFB, ALDO-A1, and lactate dehydrogenase A1 or LDHA, were inhibited after berberine treatment. Consistently, hexokinase 2, PGK1, PKM2 or pyruvate kinase M2 protein expressions were decreased after treatment with berberine. So, although berberine has effects on glucose at multiple levels, it has effects on glutamine at multiple levels. It has effects on, well, I guess the way I'll say it is that although it has those things, one of the effects that I was able to pick out was that it has effects particularly at downregulating the expression of PFKFB, which is the enzyme in question. And what I'll say is that because this target is not so well known, maybe, or I'm not really sure how to really word it, but it just doesn't have the robust amount of inhibitors that I was able to find that I had found for other kind of like key glycolytic enzymes within the actual process of glycolysis, such as hexokinase, such as the glucose transporter, such as PFK. But I still was able to find quite a bit. So as you can see here, there's a lot of question. And where there's a question, I put a question mark because I don't want it to be gospel truth at this point. Not that there ever is really, the science is never truly settled. It's always just further discoveries, kind of furthering our understanding. But I did put 3PO as a question mark, and I did put several other things that look like they may have activity upon PFKFB, in particular EGCG, curcumin, resveratrol, quercetin, apigenin, silibinin, melatonin, kind of the regular bunch, the regular bunch that are kind of responsible for shutting down the Warburg effect at multiple other levels that we see time and time again. And which is, as you can see at this point, why, things like quercetin and milk thistle, silibinin, and EGCG and curcumin, resveratrol, they're all on my list of being favorite things that can be added to someone's program. And you'd also see berberine on this list, or sulforaphane on this list as well, vitamin D, of course, of course. But the more definitive inhibitors of PFKFB3 we have are the PFK15, PFK158, that AZ67, which we didn't talk about in any papers, but was kind of talked about when they were kind of trying to debunk the PF3PO studies. And then metformin, 1,25-hydroxy, the activated form of vitamin D, has an effect here. Sulforaphane, berberine, that beta-alanine, which we talked about, and then salviolinic acid, C, have definitive roles at inhibiting or downregulating PFKFB3. So I think there needs to be a lot of research in this arena still. And I think that this is definitely an important target. And, maybe the question would be, would you specifically target PFKFB3 in a vacuum? Well, probably I'm not going to be inhibiting PFK3 in a vacuum or any other key enzyme. What I do believe in is redundancy. So if we were to look at glycolysis de novo again, this is not a great graphic for that. We could use this graphic though. So, I like redundancy, right? So if, for example, I think I like the idea of blocking, first of all, before I get there, I like the idea of lowering blood glucose. I like the idea of putting you on a ketogenic diet, shunting glucose away from tumor cells using a variety of mechanisms. I like the idea of blocking glucose transporters and hexokinase and PFK. But since PFKFB has a strong enhancement role on PFK, I do think that makes sense. Now, the question is, would you use a specific inhibitor for that? Well, the question is, do we have to, right? Because the bottom line is, you're probably already going to be on vitamin D and metformin and maybe berberine and, I don't know, quercetin and some of these other things already as part of your strategy. And therefore, you're already having, influence over that. Would you add in a specific PFK158 or PFK15 inhibitor? I don't know. I think it's too early to say. These are all kind of like preclinical and clinical models not used in humans. It seems like these have a really powerful effect. And, once we understand how, it works within humans and maybe dosing strategies, then that could be an enhancement to metabolic therapy. I do think that could be a possibility. But when you have so many things that you may or may not already be taking as part of your regimen, maybe you may not need to add those things, the more kind of like drug inhibitors. Or maybe if you want to use drug inhibitors, maybe you're going to lean more towards the repurposed medications like the metformin, et cetera. So that's what I got about PFKFB3. It's been a pretty interesting journey getting to this point, because if you want me to be very honest with you, I had never heard of PFKFB3 in my life. My undergraduate degree is in biochemistry. I'm a medical doctor. I study cancers and metabolic disease. And it wasn't until about a month ago had I even heard about this enzyme when doing my due diligence for the PFK1 videos. And this came up on my radar, and it seemed important enough to talk about as a therapeutic strategy. And therefore, I did not want to leave that stone unturned. And so therefore, here we are. We have quite a few comments that have come up in the last couple of minutes. So you're welcome. Thank you for your support, Cam's dad. Do you think right to try will thrive with RFK? I think that we are in a very fragile state right now. There actually is an internal MAHA war, if you're actually paying attention. There are influencers within the MAHA space that are kind of at odds with each other about certain picks at certain key positions within the administration. So therefore, I don't know the answer to that. I'm hopeful, but I'm also cautiously optimistic because I just know how powerful industry is and how, the status quo, there's a lot of money in the status quo. This is fascinating. Thank you. You're very welcome, Corey. I appreciate your live streams, great information, and do watching them later if I do miss the live. Yeah, look, I'm glad you like the lives because I'm going to keep doing them because I don't have enough time to produce the videos, to be very honest with you. It's going to be, maybe I can produce like one video a month. In this case, because I'm going to do a little micro series on ivermectin, next week. I'm going to put at least one video out Monday. I'm going to try to have maybe a second video out by either Friday or the following Monday, but it just takes a lot more time. And since my family's in town, I'm not going to have it. So therefore, I'm going to probably have to bring these ivermectin videos out slowly. But I'm going to keep doing the lives because it's how I'm able to get the information out to you in a more timely manner. And it's important that I get this information out to you because you can see how clinically relevant these specific targets. They may be obscure, they may be not well known, but there's a lot of research being done on these very obscure targets, and I want to get you the most up-to-date information. I mean, that beta-alanine study was, I think, the most recent paper that I was able to find, and it was published in January of 2024. So a little over a year ago. So there's active research being done on this very important target. We were very excited about the ivermectin. I've been on it since the start of my cancer. Very cool, Wayne. Yeah, I was pretty bearish on it at the beginning, but now at this point of what I've done with my research, I'm pretty bullish actually. I've changed. I've done a 180. Thanks from New Zealand. Thank you. You're welcome from Florida. Looking forward to the ivermectin information. Yes, I'm hoping that I think it turned out as a pretty good video. I just finished editing it yesterday, and I think it turned out as a pretty good video. And I've took some advice from some of the people in the comments about trying to be a little bit more organized. Not that it's not organized in terms of the way I present it, but it's not obvious to the listener what information you're going to receive prior to the video. So I tried to even use some of that feedback from some of the audience, from people who probably have much better abilities at presenting information than I do. Have you considered starting a group where your audience can share resources, information, maybe Facebook or something like that? I have, Jesse. I actually, at the recommendations of actually one of my patients here in Florida, who's like, I don't know, like a super tech savvy person, they recommended a platform, which I did end up getting an account for, but I have not had the time to roll it out. That's the issue, is I don't have time. This week in particular, I'm working 85 hours at the hospital minimum. And on my weeks off, I do pick up a couple of shifts, and I'm doing consults, and I'm doing these videos and researching for the videos. So I just don't have a lot of time. Plus I'm trying to, of course, be there for my family. So it's just difficult to roll these things out. I do have it. It's in the works. Let's put it that way. Also, have you checked out Jack's content from your recommendation? Love it. Oh, you checked out Jack's content from your recommendation. Yeah, Dr. Cruz is up here. I mean, he's a world treasure. He's salty. He's a neurosurgeon. He's brilliant, and he doesn't like to, I don't want to say dumb down, but because even at a low level, he would not be dumb, but he doesn't like to lower the information to our level. He likes to keep it high, and that makes us strive to his level, which is difficult to do, or maybe even impossible to do. But yeah, came from your work, suspected thiamine deficiency, and figure out my health. Could B1 be pro-cancer? So Corey asked a question, and this is a great question about, thiamine deficiency is definitely a cause of pseudohypoxia and can lead to uncontrolled growth and activation of hypoxia-inducible factors and transformation to the Warburg effect through a mechanism, through a pyruvate dehydrogenase. But can high doses of B1 be pro-cancer? And this is I did a video on this probably last year in May or June. I have a video on high dose B1 having an effect similar to that of dichloroacetate as basically an anti-cancer agent, but it has to be high dose. And you have to really dig through the literature to see what high dose is. And high dose is defined as greater than 75 times the RDA. And so I'm going to just leave it at that, to your own devices to figure out what that would be, which is not hard to find. But low doses of B1 potentially could be pro-cancer, they're saying, but high doses have an opposite paradoxical effect, and it's because it blocks pyruvate dehydrogenase kinase, which is a key enzyme at setting up the Warburg effect. and it's under control of at least hypoxia factors as well as other pro-growth pathways. Good stuff, Doc. Appreciate the info. I've been taking screenshots and putting them up on AI just make it easier for me to follow. Cool. Sounds like you're very high tech as well. Corey, I've also recently gone down Jack Cruz rabbit hole since Doc Peebler. Holy cow, his stuff is gold. Dr. Cruz is a treasure. He probably would not be on board with what I'm talking about, be very frank, just because I know him talking about Dr. Seyfried having some things right. He calls it a partial truth or a half truth. Yeah, I'm not as hard on Dr. Seyfried as Dr. Cruz is, but I do think that Dr. Cruz is brilliant. And I've regularly listened to him. As a matter of fact, I was listening to one of his not his live streams, but he has a membership site, and I've been part of it since 2018. And I listen to it every month, and I learn something every month. Okay. Metabolic therapy has been very effective at managing my wife's GBM. Oh my God, I'm so sorry about your wife's GBM. 2 MRIs in a row, no cancer cells lighting up. That is freaking awesome. Can you please do a video or something about that? Do something and get the word out, about your wife and her GBM diagnosis. I mean, that's awesome news. I'm so happy for that, for her. I think maybe it'd be curious, a health guide for you. Could you maybe tell the group and maybe in a comment under this video, maybe what you're doing and what does metabolic therapy mean to you? Because it is kind of a broad brush, and it would be helpful for us to understand. Rock on. Thank you, Ray. Live streams add such a human touch compared to a video. I agree, Christopher. I agree. I do feel like I'm less robotic in a video. I've also, I'm a new content creator as of basically a year ago. So, I've gone through like phases of, okay, it has to be perfect. I'm cutting out every little thing. Well, then that makes the video look more robotic, and I've been accused of it being AI, and I don't know. So who knows? But I do think that the live stream adds a lot of humanity, and it also allows me to interact with you on more of a real-time basis versus me trying to between other responsibilities respond to comments. Salt is important. Yeah, Jack is salty. He is. Most. I don't know if you've noticed. If anybody. I've been a follower of Jack Cruz for a long time. Definitely on his weeks off, when he's not working as a neurosurgeon, I don't think anymore. But when over the years, when he would go up to do a locum shift wherever he was at or whatever as a neurosurgeon, and he was working as a neurosurgeon, he was definitely more salty during those weeks than he was on the weeks that he was off. And I would also notice that if he was down in Florida at his compound that he no longer has anymore, I think he's now completely in El Salvador. He's definitely less salty because I think his redox is better. I think I don't know if he notices or not, but I've always noticed it over the years. He's just more open to taking questions and elaborating on things when he's off and he's in El Salvador. But he's going to be salty no matter what. That's part of his personality. And that's also part of his MO. I think he, what is the word he always uses? I'm going to punch you in the mouth, right? I'm going to punch you in the mouth until you get it. And I think that's part of his MO anyway. So anyway, I love Jack. Great info. Love the master's level biochemistry class. Hey, I'm just learning along you guys. My undergraduate degree is in biochemistry. And of course we get biochemistry in medical school, but not to this degree, not even close to this degree. So I'm getting my own master's and PhD level. I don't know about PhD level, but my own master's level, education here at the same time alongside you guys. I've been doing high dose of B1 for about 6 months. It's almost completely reversed my dysautonomia. Wow, that's freaking awesome. That's awesome. Would you do an AMA session? Ask me anything. I've talked about doing that, and I have behind the scenes also set up a YouTube membership where maybe I would do like a once a month, like hour or 2 hour long, ask me anything type of thing. But kind of behind a paywall. So it's not, I can maybe be a little bit more candid, or maybe even going off platform and doing an ask me anything behind a paywall, like in that same, kind of vein. So I'd like to have a little bit more freedom, to be, I can't practice medicine over the internet. I can't do that. A lot of people want me to give dosages and scheduling and timing and combination approaches. And I cannot do that. As much as I want to, I can't do it because it's not legal. And it's not really ethical either. I'm not your doctor. I don't know what your specific N=1 is. But I would be open to doing an Ask Me Anything or a Q&A monthly for, again, it's not like I can invent time, but maybe like an hour a month or something like that. But I'm looking at either either a YouTube membership or maybe another membership paywall, low monthly cost, but just get people who are really serious about this and get us a place where we can talk. Does anybody have a preference of either YouTube membership or off-site off membership? I mean, what I'd probably do if it was off-site, I've thought about this kind of a lot. I've thought about doing like a weekly, or not a weekly, but a monthly Zoom where everybody who is a member could have access to the password to the Zoom and the time and the dates and everything, because you'd get information. And then you could chime in on the Zoom. And then what I could do is I could record the screen or record the Zoom like I do for my courses, for example. And then I could put it up on that site, something like that. Someone says Zoom. Catherine McCormick says Zoom. A bit worried about how long it should be. High dose, though, currently about 600 milligrams a day of split. So what I saw was there would be really no, I don't remember the milligram per kilogram dose, but it was really high. We're talking like, to get side effects from thiamine B1, you have to take like 6,000 to 8,000 milligrams of thiamine to get a detrimental effect, which is like an unbelievable amount, right? So I don't think at 600 milligrams, you're going to have a problem. I don't think you have a problem. Everyone's saying Zoom. We have talked before, keto diet, HBOT. Oh, okay, cool. Canadian flag. Welcome, my Canadian brother up there. Keto diet, HBOT, full press pulse, off-label DDW. That's awesome. You're doing a lot for your wife, and it's showing. You're having results that other people don't get with GBM. I like YouTube, but Zoom may be good. Yeah, I'm kind of thinking the same, Ted. I like that emoji. Because I think that for simplicity's sake, I think YouTube would be the best. But I think that for maybe a little more academic freedom, if you know what I mean, I think that off-site could be better, and we could have a little more control over the conversation. If you don't do the YouTube membership, you can always mention it in your YouTube videos so others can sign up. Yeah, that's true. That's true. I could just give a shout out to myself and our little community that we're building. I could also join forces with someone else. I think I've heard that Dr. Diraj has his own little community too. I'm okay to like crashing that or joining forces with them somehow, like in a more formal way. Look, I think that we do need to use YouTube for your information access to your Zoom. Yeah, that's Catherine. That's what I'm thinking. I've thought about that hard, as a matter of fact, and I have both things kind of set up in the background already, actually, for launching. It's just that I haven't had a chance to launch, but I've been interested in membership of sort. Yeah, I think a community would be nice. I'd love to have like other big names like Seafree, Diraj, many other people in the alternative space, being able to chime in there and give kind of unfiltered content there. Because anyway, I'm also just of note, some things that I'm thinking about, ways to improve the channel besides what we're doing. I'm also looking at doing like a monthly podcast too, that would not be behind a paywall. It'd just be a regular video. And I'd like to have like a guest on who has specific, kind of PhD or even clinical expertise in these particular areas that I don't have expertise in, that I want to have expertise in, that I want you to have expertise in, that can, and I would, how do I say this? I love Dr. Seafried's, videos he does with some of these content creators. But the problem is that the content creators generally don't have the level of understanding of cancer's metabolic disease that I do. So therefore, they're not able to ask the very nuanced questions that really we need as a community to move forward across to the next level, right? So therefore, I would probably it wouldn't be like a softball. Not that I would be hard on anybody by all means, but it would not be like a softball, like, tell me about cancer's metabolic disease. And you get like the very basic, kind of like, this is what cancer requires, glucose and glutamine. Like, I want more specific answers about press pulse, or I want more specific answers about HBOT, or more specific answers about whatever intervention that we'd be doing. So just keep your eyes out for that. Cause I've got okays from several kind of big people that they would do it. Actually back in like December, January timeframe, but I haven't had the time to roll it out, but I'm really thinking about doing that soon, because we are now moved into our house, and I am sitting in my podcast studio right now, and we have I mean, it's an empty room, and then you can probably even hear the echo. But we're gonna be, you know, getting this up to speed. My wife, who happens to be a video journalist and an expert in multimedia journalism, you know, is going to help me and help us, you know, basically put this studio together. And it's going to be a nice transformation. So once I have that done, hopefully like July, August timeframe, I want to start the podcast. And I think you'll all get a lot of benefit from that. Anyway, we've got an hour and 10 minutes. We've covered PFKFB3 to a large extent. Will there be more on PFKFB3? Not in the coming future, probably because I think I've done a pretty extensive literature search and found as much as I can about it for now. Yes. But that being said, that doesn't mean there couldn't be more in the future. The next enzyme we're going to be talking about is PKM2, or pyruvic kinase. That's going to be our next target of interest. But I am going to cover ivermectin on Monday through a non-live stream Mito Studio. No, Corey, like I got shut down by my wife, but I was actually trying to get a big giant like mitochondria in the background of the studio. And it's not that I can't have the mitochondria. It's just that I found a couple like cheapo like posters on Amazon, and they weren't cool. So maybe I'll have like I've even looked at maybe getting like a mitochondria that has like maybe like a neon sign, like mitochondria. Yes, exactly. Mitochondria neon sign but red, of course, because if I don't want blue light in my Mito studio. So anyway, I'm looking at doing some cool things, but that's kind of the least of the most important things. The bottom line is that we keep moving on one day at a time. We keep pressing on and seeing what the literature has to offer that we can utilize, and to come up with strategies that will, hopefully, God willing, like our friend up in Canada, and his wife with GBM, we can help each other and make strides in cancer clinical outcomes that haven't been made in 100 years, hopefully. So anyways, if you like videos like this, as always, please like it. If you're not a subscriber, please join our Mitochondriac army. And red all the way. And it has to be red. I mean, it has to be red, right? Like it would, and that's not even my favorite color. My favorite color is actually green, but red is the color to protect all of our mitochondria. So anyway, with that being said, if you haven't joined our Mitochondriac army, please consider subscribing. It is free. And until next time.